Let me introduce two very valuable players of the team. Dr. Meyer is the director of the neurorehabilitation unit here at Johns Hopkins Hospital. When patients come to us with acute myelitis, myelopathies, Dr. Meyer is helping us to initiate the rehabilitation plan, and we always appreciate the role of rehabilitation specialists, physiatrists, because they are extremely, extremely important for the process of rehabilitation. Meredith is here. Meredith is from the International Neurorehabilitation Institute in Towson. Meredith is a fantastic therapist. She came to our clinics in the past, and she always helped us to organize and give advice and counseling to our patients with transverse myelitis. And Sam and Meredith, thank you so much for helping us. So, all right, ready to work.
Well, we're going to make this pretty informal and kind of go through a little. Hi, can everybody hear me? Okay. So we'll keep it pretty informal, and please, interrupt us along the way if you have some questions about what we're talking about. And, we also got a whole huge stack of questions, so thank you. We'll try to get through all those as well. What we'll do is spend the first part kind of giving you an outline of kind of the algorithm of how we deal with spasticity, and talk about what it is, and both managing it with non-medications and medications. Dr. Newsom's talk was a great lead into this. So he laid down a lot of the groundwork about how we manage spasticity, and we'll kind of go through that. Want to maybe start off with is a little bit about what spasticity is, and both problems with it and also benefits of it. And then I'm going to turn it over to Meredith, and she's going to talk about the non-pharmacologic treatments, which I think are probably the mainstay that we should always be using. Every patient can benefit from those. And then in cases where that's not working, the medications can help in addition. And I think it's really important to look at it that way, is that this isn't something where you pop a pill and you're better. And really, most of the non-pharmacologic things that we do are more important than what we do in terms of medications. So really want to emphasize that. So spasticity is basically when muscle groups are fighting against each other. And it comes from this miswiring of the spinal cord. There are neurons within the spinal cord called interneurons that act to control the signals and kind of damper down the signals as you move and help you move in a controlled fashion. And those get damaged by TM. And when those are damaged, it causes some muscles to be overactive and some muscles to be underactive, and that's essentially what spasticity is. So it's a rather complicated process, and there are other things that increase muscle tone too that don't happen too often in transverse myelitis, but it's important to sort through those things because they have a different chemistry than spasticity. So, for example, Parkinson's patients get a different type of increased muscle tone. But in terms of the abnormal muscle tone, some of it is helpful, particularly in your legs. Can be helpful in terms of standing. Maybe some of you have experienced that, is that when you're weak in your legs, you can often use the muscle tone that you get in your legs to help you stand up and help you walk. And we don't want to take that away. So it's important to have some muscle tone because it helps with those, particularly what we call extensor tone. Things that straighten your legs can help you stand. And so some degree of that is very helpful if you're weak in your legs. It's also important to keep up your circulation. So we know that spasticity helps prevent blood clots in the legs, for example. So there are some really good things that spasticity does, and we don't want to take it all away. And one of the problems with medications that we'll talk about a little later is that if we use too strong a medication or use it inappropriately, you can wind up weakening those muscles, and you can wind up worse. So we don't want to do that. So we always want to think about how it's impacting things. So we want to think about what the spasticity is getting in the way of, too. And one of the things I always start off with my patients is I want to talk about their goals. That's a real key part of rehabilitation. We're always working on things with you. It's not things we do to you, it's things we do with you. And we want to know what your goals are and try to draw 1, 2, 3 specific goals we call SMART goals: specific, measurable, achievable, relevant to you, and time-related goals. So SMART is the acronym we use to think about what are we going to achieve by treating your spasticity. So, for example, if you have spasticity in the shoulders and you have trouble putting on a shirt, maybe your goal is to put on that shirt by yourself, okay? And we can set that as a goal. So the more specific we can be, the better we are at measuring whether we're achieving what we want to do. And so you should think about that when you're talking to your doctors about treating your spasticity, is what do you want to accomplish by it? Because it's not fixing a physical exam finding, it's fixing a person, right? And how is it impacting you? So whether it's pain, whether it's moving around in certain ways, we need to think about that and then adjust the therapy accordingly. So with that, why don't I let Meredith talk a little bit about some of the non-pharmacological stuff that we do.
So I think the most obvious thing is stretching. And I'm sure most of you have gone to rehab and your therapist has suggested that you stretch. The most important thing to consider when you're stretching is how you're stretching and how long you're stretching. Many of my patients will say, oh yes, I stretch. But they may stretch once a week, they may stretch once a day for 30 seconds, if that. The research shows that in order to effectively stretch, you need to at least hold it for 30 seconds. And that's for an athlete. For someone that has spasticity, research shows that you need to have a low-load, prolonged stretch. So it's not unusual that I might recommend to my patients that they stretch for up to an hour a day. And that doesn't mean an hour all at once, but throughout the day. And I think that you'll start to see better benefits from the stretching when you do it for a prolonged period of time. The stretching for an hour can be difficult. It can be hard to do if your spasticity is incredibly bad, and it can be really fatiguing on the person that's helping you to stretch if you can't do it on your own. So one thing that we'll often do for patients is serial casting. Sure, many of you have heard of that, or making splints. There's a lot of things to consider when you want to put a cast on somebody, particularly skin integrity, decreased sensation. Sometimes it's hard for us to know if the cast is too tight, and then that can be risky once the cast is taken off. They're usually on for about a week or more, so then you have to consider transportation and how big is the cast that you're putting on, so can you get in and out of a car to go to the center where they're going to take the cast on and off? Are you going to be able to walk if you do walk? Are you going to be able to get in and out of your wheelchair if you need a wheelchair? So they do make other types of casts that come on and off, and you can also use your orthotist to get daily splints. Other things that I do within my therapy center and that you can ask your therapist about is ultrasound. It's not uncommon that I will stretch a muscle in conjunction with using ultrasound so that I can provide the heat specifically to the muscle that I'm trying to reduce the spasticity in, and we know that heat can help reduce spasticity. In our clinic, we use a lot of functional electrical stimulation, but another type of stimulation that I'm sure many of you have heard about is called TENS. That's frequently recommended for low back pain, but it can also be used to help reduce spasticity by relaxing the muscles that are really spastic. I will usually recommend that my patients, if they have really bad spasticity, will put TENS on while they're stretching so that they can effectively help them to relax. Also, functional electrical stimulation can help, and that can be a little controversial. Some patients will say, well, that actually made my spasticity worse. And I think it depends on the chronicity of your injury. I have worked with patients that are very acutely injured, and in fact, when they start using FES, their spasticity is getting worse. A lot of that can be because of the nature and the evolution of the TM, and that it just happens to coincide with the time that it started being used. FES can reduce tone. It needs to be used regularly and for a prolonged period to fatigue the muscle. And that's the goal of using FES for tone reduction, not specifically to strengthen, but rather to fatigue that muscle and to fatigue the spasticity. And then weight bearing is another way that you can help reduce tone. So for people who do use a wheelchair, you can use supported standers. And for those that are able to stand, that can help with tone reduction. Specifically, if you do have better balance, standing on the affected limb, if one is affected more than the other. So those are all the ways that therapy can help, and I'd be glad to answer more questions or specific questions pertaining to each individual intervention.
So let me describe a little bit of kind of the algorithm I use to treat patients with spasticity. So besides looking at function, my next question is what muscles are affected and how many? And we kind of divide things in half, but it's not always so neat and tidy. But in general, if the spasticity involves one or two limbs and a few muscles, we treat it one way, and if it's more generalized, involving two or more limbs and multiple muscles, okay. I did that earlier, but let me. Somebody maybe come in late. So spasticity is this abnormal contraction of muscles, and where muscles are fighting each other. Is kind of the simple way of putting it, and it's because of misconnections in the spinal cord. So it can be either. So some people have muscle spasms that last anywhere from a few seconds to an hour or two. And other people have abnormal tone all day long that last indefinitely. And and often people have both. The muscle spasms are often painful, probably about 75% of the time, but some people have muscle spasms or have what we call clonus, where your muscles will shake, particularly at the ankle, and that may not be painful for some people. So you may have noticed that too. So that's one of the findings that we see with spasticity. Yes, so certainly when you're more fatigued, most people get more spastic. So often time of day makes a big difference. So a lot of people are worse late in the afternoon. Some people have a lot of problems at night too and have difficulty sleeping because of it. Other people are stiff when they wake up in the morning. It's unpredictable. So as many different people in the room as there are probably different ways your spasticity affects you. So that's one of the challenges, and we have to really get a sense of that. Yeah. So I think Dr. Newsom said, and I think very rightly, that sometimes pain and spasms are a good sign in terms of recovery, particularly early on in the disease, in the first couple months. We often see that as patients are recovering motor function, these things get worse. And it's, of course, very scary for the patient because you're worried, am I getting worse or am I getting better? So sometimes it's a very optimistic sign that we see as patients are recovering, they get more pain problems, particularly like what we call paresthesias, burning, tingling sensations, as things are waking up, kind of like when your leg falls asleep and it wakes up. And we also see that as your connections are forming in your spinal cord, you may go from having a limb that's completely flaccid to one that gets spastic. So that can be a sign things are recovering. Yeah. Well, that's probably spasm, but that's a part of spasticity. So it is a, within the spectrum of spasticity. Back there. Mm-hmm. Mm-hmm. Yeah, so I think Dr. Newsom covered this a little bit when he talked about musculoskeletal pain, is that when you have weak muscles, irrespective of spasm, but if the muscles are just weak, it's going to cause some abnormal forces on the joints. And it sounds like that may be what's occurring with your wife. And so there are things that can be done in therapy with that. Sometimes some bracing may help. Trying to do what we can to correct the gait pattern can help. I don't know if you want to.
I was going to say, typically, just like when someone has arthritis in a joint, the best thing to do is strengthen the muscles that surround the joint. And that could help to make the gait pattern more normal. Because as he said, I will see a lot of people with pain in joints, and it is usually a result of the unequal tension that the muscles are creating by pulling on the joint based on their strength and their tightness. A recumbent bike is a good exercise to help with knee pain, yeah, because it strengthens the hamstrings and the quadriceps, so it's supporting the joint itself. But ultimately, I would have a therapist thoroughly assess your wife so that she can determine specifically which muscles are causing her knee to either be malaligned or causing her knee to buckle. Mm-hmm.
So I'm 34 years. I've had a lot of past 2 years, and my take on it has always been I've been chronically dehydrated for surgeon's letter, and muscle side was being non-tendon.
Mm-hmm.
So I've had a number of prolotherapies, by no means a cure. I've got ongoing arthritis. I think it's all really
During the gait lecture, she mentioned when your knees hyperextend, which is incredibly common in people that have gait disorders. And when that happens, your bones are just locking and rubbing on each other. Sometimes people are okay with that and they think, oh, I'm able to stand, I have stability. But the reality is the damage it's doing is far worse than the good it's doing that you're able to stand, because down the road you will get arthritis. And it actually doesn't give your muscles an opportunity to strengthen. It turns into your bones supporting the joint, and your muscles aren't engaging or as active as we would want them to be. Yeah. Yeah. She mentioned quadriceps. If this happens to any of you, I encourage you to have your therapist help you with your hamstring strength, because I happen to find that being weak is a far greater impact on your knee hyperextending than your quadriceps. Yeah. Yeah.
So actually somebody asked a question along the same lines about long-term effects of spasticity, and that's certainly one of the big long-term effects. especially, I don't know if you were a child. You look like you were a child when back. You had that. Yeah, but in growing children, this is particularly a problem. So before your bones fully form, if you have spasticity as a child, it can lead to malformation of the hips and other joints. So that's a big deal. But even in adults, you get these abnormal wear and tear patterns and eventually do get arthritis. So, yeah, that's another big impact. I'm sorry, go ahead. I've stopped advertising mattresses. I think it's very individual. And one thing that I would be a little cautious about is the hospital-type beds that elevate the head up if you're spending a lot of time in bed. Because if you're spending a lot of time in bed like that or sleeping in a recliner, I have a lot of patients that like to sleep in recliners. Unfortunately, if you spend too much time in a recliner, you begin to look like the recliner. And that's a big problem. You get contractures in your hips and in your knees, and can be really problematic. So even if it's comfortable, to some degree, you have to be a little bit uncomfortable and stretch those muscles every night. So it's a problem. But, you know, some people like the softer mattresses, some harder mattresses. Yeah, and there's, you know, in terms of back pain, which has been much better studied than, of course, DM, because it's much more common, there's no evidence that the type of mattress prevents back pain or helps back pain in spite of all the ads on TV. Yeah. So throw out the lazy boy if you can. But getting back to how we look at patients, I was saying that we look at it as either generalized spasticity or localized spasticity. So if it's generalized, meaning it involves multiple muscles, then we usually have to think of treating it systemically with something that's going to work all over the body. And one of the first questions we have, I think somebody asked in the audience last lecture about having some new problems with their bladder and then having some spasms, and whether they were related. And that's an excellent question, and something we always have to ask our patients is when they've been stable with their spasticity for a while, and then all of a sudden something comes in and over the last week or so they've gotten more spastic, it usually means that there's some irritant to the body. Commonly that's a urinary tract infection or a pressure sore. It can be emotional stress can do it. It can be, any kind of an infection coming on, anything from a cold to a much more serious infection, pneumonia. So that's a big trigger, and sometimes, particularly those of you that have trouble with sensation, you may not feel anything else other than the spasms triggering it. I mean, people are known to have attacks of appendicitis, for example, that just come on. You don't get abdominal pain because you don't have any sensation there, but you get severe spasticity, and we have to find where it's coming from. So, especially if you're having fevers or anything like that, you need to go see a doctor right away when that happens. Yeah. Okay. Not true. Yeah. So, are you able to explain what autonomic hyperreflexia is to the audience, or do you want me to do it?
Well, all right.
Do you want to?
So it's your body's response to any noxious stimuli. So most physicians, I think, are taught about it in the content in the context of paraplegia or quadriplegia. A lot of times it's if the patient's impacted or their catheter's kinked or a UTI. This is kind of in their box thinking, autonomic dysreflexia. You can have symptoms of, let's see, goosebumps, sweating above the level of injury, cool, clammy skin below the level of injury, headache, nausea, but most physicians interpret it as a hypertensive crisis, which I disagree. All right, if you're quadriplegic and you end up with all those full-blown symptoms, maybe then it is an urgent situation. I know when it's coming on. Like, I know when I'm starting to have, I think it comes in tears, If there is some noxious stimuli, heat, humidity, that's a good one. I know to intervene early. But anytime I say those words to a doctor, no, absolutely not. That's an emergent situation.
So you're absolutely right, is that you want to pay attention to these things and treat it before it gets to be that. And most of the time the treatment's just removing whatever is the noxious situation rather than pulling out the pill box. But it can be very dangerous because it can cause those emergent situations. So if it's left untreated, it can rapidly progress to really high blood pressures and strokes and seizures and all kinds of bad stuff. So that's why. Anyway, so for generalized spasticity, we usually start off with, once we've done all the conservative things, we also may consider adding medications by mouth usually to start. And the mainstay of medications, probably the first used one most of the time for spinal cord related spasticity is Baclofen. So many of you may be on that medication. It works pretty well. It does have a lot of side effects, and all these medications have a lot of side effects, unfortunately. So it varies quite a bit. We usually start off with 5 milligrams, sometimes just at night, and then go up. It's more typically a 3-time-a-day medication. Some people take it 4 times a day. The maximal dose, according to the FDA, is 80 milligrams a day total, which would be 20 milligrams 4 times a day. But on occasion, if somebody's not having side effects, we may go higher to control things. But we usually try to optimize that one first, unless there's some other issues, allergies or other things. So the range is from 5 milligrams a day to 80 milligrams is what the FDA says. I have some patients on 120 milligrams a day. But most patients don't tolerate that high a dose, and we'll talk a little bit about what happens when they don't. So there are a lot of side effects, and they are mostly dose related, so that the higher the dose, the more likely you are to get side effects. Main one is drowsiness. Some people can get problems with their liver with it. There is also muscle weakness that happens with any of these, is that it can cause some weakness in your muscles. And, for example, if you're using that spasticity tone to stand up, your knees can start buckling. It can have effects on your bladder, both positive and negative. So some people will develop incontinence on it because it's loosening the muscles that control the sphincters, that control your urination. So those are some of the side effects we see. The other thing with Baclofen is that if it's quickly stopped, it causes problems. So you can get severe spasms if it's stopped overnight, and particularly if you're on a higher dose. And you can even get seizures, and you can even die from that. So you should never run out of Baclofen. So there is not an IV form of it, and that's one of the problems. Usually we have to use Valium as a substitute, which is a poor substitute. It can work okay in short term, and it can prevent seizures, but that is a problem if somebody can't take it by mouth for some reason. So if you are on Baclofen and you're going to have some kind of abdominal surgery or something like that, I think you need to work with your doctors ahead of time and let them know that, because they may not think about that. You know, if you go to a general surgeon and you're going to have your gallbladder out, for example, they may not be aware of that. It depends on what dose you're on. So if you're on a very high dose, 12 hours might be enough to trigger a reaction. If you're on a lower dose, it may not be a big deal. Tegretol doesn't really work for spasticity. It can work for pain, but it's not a very good spasticity agent. And there's a ton of side effects to Tegretol, but that's a little beyond what we're going to talk about here. And Beck, I think you had a question? Depending on the situation, how long you've been on it, but if you're on 80 milligrams a day, I would probably take you down by about 10 milligrams every other day or so. So, yeah, you can't cut it off all of a sudden. Okay. Next oral medication we might consider is something called tizanidine. And tizanidine is medicine that's actually derived from a blood pressure medicine called clonidine. They're very close, and clonidine also has some anti-spasticity effects. But because it's essentially a blood pressure medicine, we're not sure exactly how it works in the spinal cord, but it does. We know it blocks a certain type of pathway, but called the alpha system. But exactly why that works in spasticity, we don't quite understand. But the biggest side effect to it is something called orthostatic hypotension, which means when you stand up, your blood pressure drops. And that can be serious because you can pass out. So we have to be careful with that. Yeah. Tizanidine is Xanaflex. I'm going to try to use generic names primarily, but remind me and I'll try to give you the brand name as well. I think all the medication I'm going to talk about are available in generic. Unfortunately, there isn't anything brand new in oral medication for spasticity, which is really disappointing because the medicines, quite frankly, aren't great ones. They all have tons of side effects. And has not been a big interest to the pharmaceutical industry for some reason. I guess I don't think they can make much money in it, so they haven't come out with. Tizanidine is actually the newest drug of them, and I think that's been out about 25, 30 years. So. Yeah. So, and I was going to get to Valium next, so we can talk about that. So Valium or diazepam, and there's some related medicines. Clonazepam is another one that's in that family. I think are good for acute spasm. So somebody comes in and has a painful spasm in the hospital or something like that. It actually works quite well. Longer term, the problem with it is your body adjusts to it very rapidly. And there, as probably heard in the press, Valium can be very addictive. And so people wind up using higher and higher doses, and we have to be really careful about that. It also can't be stopped abruptly like Baclofen. But in some patients, we have to use it as an adjunct to other medications if other things aren't working. It tends to cause a whole lot of drowsiness, probably more so than the other medicines that we're going to talk about. So tizanidine probably has less problems with it than the Valium in terms of that aspect of things. So it's a consideration to switch it over if you haven't tried that. Another medicine that we use for spasticity works in an entirely different way. It doesn't work on the nervous system, it works on the muscles. It's called dantrolene, or Dantrium is a trade name. And it works on, we call it calcium channels in the muscles. And so it doesn't have any cognitive effects, which is great. The bad part is that it makes all muscles weak, normal muscles and spastic muscles. And so generally I don't use it in people who are fairly mobile. So somebody uses a wheelchair all the time, it can be an excellent medicine. It's not a great medicine for people who have a goal of walking or moving around more. But that's another choice. Dantrium in very high doses can. That's one of the risks, but the other ones don't. They work on just what we call skeletal muscle. So, so those are the mainstays of oral medication. There's also medical marijuana. So marijuana does have anti-spasticity properties. It's actually one of the things that's been best studied for. The trouble is I can't tell you what dose to take. You know, I don't know how many joints it takes and so forth. So that's my hesitation with it. There is an oral medicine that's derived from marijuana that is legal in all 50 states, and marijuana is now legal in about half the states for medical purposes. It will be shortly in Maryland. But that drug is called Marinol or Dronabinol, is the generic name, and that can be a good alternative, and that we do know how to dose. So that's another one that we can use. But because the oral medicines have so many side effects and a lot of people can't tolerate them, we often wind up going to what's called a Baclofen pump. And I actually brought a little model with me, but if we take the Baclofen and we inject it direct into the nervous system, in your handout there's a little picture of a Baclofen pump, but it is a device that looks like this, and it goes in your abdomen, underneath your skin, and then there's a tube that comes off of it and goes into your spinal column and injects it into the spinal fluid. So you have fluid that goes around your brain and your spinal cord called the CSF, or cerebrospinal fluid. And it injects medicine direct into the cerebrospinal fluid. And by doing that, you wind up using a lot less Baclofen, like 1/50th the dose that you take by mouth. And therefore, it has a much more profound effect, and also can be easier to adjust the effect. And you get less systemic side effects, so it's not going all over your body, it's going specifically into the spinal cord. So there's a lot of advantages to that. That pump has a fancy computer that we can program it minute by minute, so if you need more dose at night, we can give you more at night. If you find that you have spasms between 4 and 6 in the afternoon every day, we can give you a dose at 4 o'clock or whatever to treat it. So it's a really nice device from that. There are problems with it, though. There are a lot of mechanical problems that we have with it, primarily not with the pump itself. The pump is very reliable, but the catheter that connects from the pump to the spinal cord can come apart. So I actually had a lady in clinic yesterday that happened to, where it pulled off the pump, or it can get kinked, or there can also be scar tissue that develops around the end of it in the spinal cord. And all those situations can lead to a withdrawal of the baclofen. And the problems that I talked about with cutting baclofen out all of a sudden can happen. So there's that risk. There's also a risk of surgery, risk of infection, some other things. So it's not for everybody. It's certainly not a miracle cure, but for some of those people that have really bad generalized spasticity that you can't treat with medications, it's a good alternative. So that's kind of our range of things for generalized spasticity. Back. So the pump lasts, the battery life on it is about 7 years, depending on what dose you're taking. And interestingly, people with TM and with multiple sclerosis who get these pumps usually wind up with a lower dose than other types of patients, like traumatic spinal cord injury patients. We don't know why that is exactly, but it might have to do with the amount of protein fluid. But in any event, the lower the dose that you're giving through it, the longer it lasts in terms of the pump and the battery life. But generally it lasts somewhere 7 years. I've had patients who've been able to keep their pumps in 10 years. And when it gets changed, you have to change out that metal piece in the abdomen. You don't have to change out the whole system. So it's a relatively shorter surgery. So they just pull this out and put in a new one. The catheter stays in. They just reconnect it to the same catheter. Sometimes the catheters have to be replaced because of some of those other mechanical problems too. So
I just wanted to interrupt for 1 second. We're not all going to be reconvening again, so I wanted to take the opportunity to just thank everyone for coming. And Dr. Mayer and Meredith have volunteered their time, so I don't want to keep them all day. But maybe if you all want to wrap up in the next 5 or 10 minutes. And I want to thank you all so much for coming and hope that this was a valuable opportunity for you all. And that's really all. Thank you.
Boo hiss. Anyway, in regard to localized spasticity, I just want to fairly quickly go over that because people may have a lot of questions about injections into muscles. So when things are more localized and only a few muscles are involved, we don't like to use medicines that work for the whole body. So in those situations, we do injections. So for smaller muscles, we like to use botulinum toxin, or Botox is the most common brand, but there's actually 4 botulinum toxins on the market now. So using one of those get injected about every 3 or 4 months. What? Mostly muscles in the arms, but some of the muscles in the legs are also smaller. If it's a bigger muscle, it tends not to work as well, and we also have limitations on how much dose we can use because it causes trouble swallowing in high doses and even trouble breathing. For that, I like to use a preparation called phenol, which deadens the nerves in a little different way, but can work real well for leg muscles. So that's another alternative. And that one lasts a lot longer. So that lasts about 6 months to a year. So we have a full stack of questions. What happened to this? Oh, okay. Went off for a second. If you all want to stick around for those, we can kind of go through a few of them. And if people have to leave, certainly feel free to take off if you need to, okay?
Sure. So the first question is, does stretching with FES help relax the muscle? And I touched on that just a little bit. Ultimately, you always need to stretch the spastic muscle. When I teach patients that I work with how to stretch, I may teach them how to use stimulation in 2 different ways to help with the stretch. And the first way is that TENS. That's using sensory stimulation. It won't produce a contraction specifically on the spastic muscle. So a lot of times people have very spastic hamstrings, for instance. If I'm teaching them how to stretch their hamstring, I may suggest that they use that sensory level stimulation on the hamstring. It doesn't work for everyone, and typically it will only last as long as you use the stimulation. So for instance, if you had it on for an hour, people will report that for the next hour, they may find that the tone is, or spasticity is slightly reduced, but then after that it will return. I also will teach my patients how to use FES on the opposite muscle. So if I'm teaching them how to stretch their hamstrings, then I will use the contractile stimulation on their quadriceps, which is the muscle that does the opposite motion. And I'll do that because in order to effectively reduce the spasticity and improve function, you have to strengthen the opposite muscles so that they can help to fight that spasticity. And that's especially important for function. So I wouldn't encourage you to look on YouTube for functional electrical stimulation, although yes, you will find it on YouTube. You'll find a lot. I would say that you should really go to a therapist, and all therapists are educated on e-stim. Not all therapists are competent in it, and that can strictly be because of lack of experience. But they do have some education, and it's important because when I use stimulation on somebody, before I teach them how, I do a whole stim eval. In other words, I'm checking what settings the person responds to and also what settings the person tolerates, because stimulation can be uncomfortable. It's quite often uncomfortable. It doesn't have to be, but you need someone that can help you to figure out the settings that will be more comfortable, or else you're not going to do it, and then you won't get the effects. I'll tell you this. Someone asked earlier how you can find a good therapist. And when I tell people that I work with who say can't stay in Baltimore forever, they ultimately have to go home to their home-based therapist, I usually suggest that they not only ask if they have experience with transverse myelitis or spinal cord injury, but I will specifically ask if they have experience with functional electrical stimulation, experience with gait training over a treadmill, and aquatic therapy. And the other thing I will ask them to ask the clinic is if their therapist doesn't, are they willing to learn? And I'll very frequently give my phone number or let them, give my phone number to the therapist. And you'll find a good therapist if they're willing to call and look for the answers. It sure has, yeah. Yeah. The next question is, does increased exercise plus FES provide better sensations? I'm not sure specifically if that means, does it decrease pain sensations, but I can't say that it will specifically improve or recover sensation. However, that's our hope, and we know that it helps. There isn't a lot of research specifically just with FES because you'd have to cut out all the other interventions, and people aren't really willing to cut out the therapy and all the other interventions. Do you want to ask one?
Sure. So I got a couple questions along this lines. This particular patient is taking gabapentin, clonazepam, and Baclofen, and says they have spasticity not often, but kicks in when I take off the pressure stockings or the legs are straight and stiff. Also when they stand up from sitting and get to the walker. And, how do you treat this intermittent spasticity or spasms? And that's a tricky question. So I think it depends on how it's affecting. So if you have them occasionally and they aren't really getting away of things, I would lean towards not treating that and minimizing the amount of medications. If, you do get once or twice a day where it's really severe and you can't do anything else about it, there are a couple of tricks. So there's some positioning tricks. So sometimes flexing your toes can can eliminate it. If you can reach down and flex your toes, or rubbing the muscle can help. A hot pack or a cold pack can help. Some people respond better to heat, some respond better to cold. So those simple things are often better than popping a medication. Trouble is, if it's something that only lasts a minute or two and you pop a pill, the pill won't take effect for another half hour or so, and then you're going to get all the side effects of the pill and none of the benefit. So that's kind of a difficult situation to deal with medications. If it's predictable what time of day, sometimes we can adjust when you take your pills, or if you're on a Baclofen pump, we can definitely adjust things to that specific time of day. If you know, it's every evening around dinner time that you're having problems, for example.
I think Dr. Pardo said we needed to wrap up. I have a bunch of questions here that are about FES. Hopefully I've answered most of them. If not, you can come and ask me. A lot of the other questions that I see here have to do with nighttime and then specifically joint damage and spasms around the ankle and the foot. I highly, highly recommend using splinting as a way to reduce spasms, particularly throughout the evening if you can tolerate them. A lot of people tell me that when they wake up in the morning, they're very stiff for quite a while. And that's because unless you're using a brace or an orthotic, we usually, when our legs are resting, are in bad positions that the spastic muscles are highly activated and they increase the tightness in the muscle. So now you've stretched for an hour during the day, say your calf muscle is spastic, and then you go to bed and your foot is pointing down. And so all your hard work kind of goes to waste. I highly recommend exploring splinting options, particularly that you can tolerate sleeping in. When I used to do acute rehab, it was a standard of care that I had my patients wear knee immobilizers and ankle orthotics so that their hamstrings and their calf muscles didn't get too tight. Because I know that's very common. Positioning, even if you're not using splinting or if you can't tolerate it, is really important. People will tend to put pillows underneath their knees, which causes the hamstrings to get very, very tight and can influence that spasticity. So I think it's important to talk to your therapist about positioning and different orthotic options that you can use, and then that will take care of your stretching. If you can use those, then you kind of get more bang for your buck because you're preventing the loss of range of motion that results from spasticity, but you're also providing a stretch in the evening and throughout the night when you're sleeping. So it's one less thing that you have to do during your wake hours.
Any other burning questions that we didn't answer?
We are ready to close the door.
All right.
Because our colleague already finished there.
All right. Well, thank you. All right. We'll be available for a few minutes afterwards if you want to catch us individually.